Every time a runner's foot collides with the ground, the lower leg must instantly absorb massive kinetic forces. When those forces exceed the structural tolerance of the bone, the leg fails. For decades, the standard clinical response to this resulting lower leg pain has been entirely localized. Practitioners prescribe ice, apply cross-friction massage directly to the sore tissue, or insert generic arch supports to try and brace the arch. These localized treatments frequently fail. The reason is straightforward. Shin splints is not an actual medical diagnosis. It is a colloquial, catch-all term that groups together entirely different mechanical failures. True medial tibial stress syndrome, or posterior shin splints, along with anterior shin splints, are specific pathologies. Both involve micro-tearing and inflammation of the periosteum, the connective tissue covering the bone, brought on by severe, repetitive mechanical overload. By focusing treatment strictly on the inflamed shin, a practitioner is only treating the victim. The sore tibia is simply reacting to forces it cannot control, while the true mechanical culprit remains completely ignored. Those culprits are found further up the kinetic chain. The actual drivers of tibial stress are proximal biomechanical leaks, specifically restricted internal rotation at the hip joint and an anterior tilt of the pelvis. To achieve permanent resolution of tibial stress, rehabilitation must move past isolated lower leg diagnostics. We have to map the ascending and descending kinetic chain failures that force the lower leg into a state of structural overload. This split-screen 3D model shows the distinct anatomical separation between the two primary types of tibial overload. Identifying the exact location of the micro-tearing tells us which muscle groups are failing. On the inner edge, we find medial tibial stress syndrome. This pathology involves the deep posterior muscles, the tibialis posterior, flexor digitorum longus, and soleus. These attach directly to the lower third of the inner shin bone, and their failure pulls sharply on the bone's outer lining. On the front and outer side of the leg are anterior shin splints. This primarily affects the belly of the tibialis anterior muscle and the deep fascia encapsulating the anterior compartment. Before mapping the biomechanical failures causing these specific strains, clinical assessment requires ruling out two severe related conditions that present with highly similar symptoms. The first is a tibial stress fracture. Unlike the diffuse ache of standard tibial stress, a fracture presents as severe pinpoint tenderness isolated to an area smaller than 3 centimeters. This is quickly identified using the single-leg hop test, where hopping on the affected leg produces intolerable localized pain within 3 jumps. This graph maps intracompartmental pressure to identify chronic exertional compartment syndrome, or CECS. Exercise causes swelling inside a tight muscle compartment, restricting blood flow and causing transient neurological symptoms like foot numbness. The diagnostic signature of CECS is that the pain and pressure drop sharply and vanish within 15 minutes of stopping activity. Once severe conditions are cleared, diagnosis relies on physical provocation. The shin palpation test confirms medial stress if widespread tenderness spans more than 5 centimeters along the bone. Resisted muscle testing, having the patient invert, plantar flex, or dorsiflex the foot against pressure, isolates exactly which muscular attachments are inflamed. Medical imaging supports these clinical findings, though standard X-rays almost always return completely normal results. An MRI serves as the diagnostic gold standard here, capable of exposing the periosteal edema, the fluid and inflammation in the bone's outer lining. Locating the exact site of the periosteal edema confirms the specific local diagnosis. It tells us which tissues are failing, but it offers zero explanation as to why those specific tissues are being overloaded in the first place. This timeline breaks down the running gait cycle to reveal the specific mechanical triggers. Tissue micro-tearing manifests at highly predictable moments when the muscular demand exceeds structural tolerance. Medial tibial stress syndrome occurs squarely within the loading response and mid-stance phases. Immediately after the heel strikes, the foot relies on inward subtalar pronation to absorb the shock of impact. To prevent the arch from collapsing instantly, the tibialis posterior must execute a massive eccentric contraction. The muscle is forced to lengthen while under tension to act as a brake. If the foot overpronates, this braking force exerts immense, destructive traction directly onto the medial shin bone. Anterior shin splints present a different mechanical profile. The structural overload here is split across two entirely separate phases of the running gait. The first point of failure happens the exact millisecond the heel hits the ground. Gravity tries to slam the forefoot down, forcing the anterior shin muscles into a severe eccentric contraction to decelerate the foot and prevent a violent slap against the pavement. The second point of failure occurs during the swing period. Once the foot leaves the ground, the tibialis anterior must fire concentrically, shortening to pull the toes upward. If the foot is hypermobile from pronation, the anterior muscles suffer continuous fatigue strain just to keep the toes from dragging. Local tissue trauma is the direct result of eccentric braking forces during impact and concentric fatigue during swing. To stop the trauma, we have to identify why these specific muscular demands are so unnaturally high. We find the root cause by moving the diagnostic focus upward. By leaving the localized mechanics of the foot and ankle, we can locate the systemic errors originating in the pelvis and hip. This lateral view illustrates an anterior pelvic tilt, a downward cascading error in the descending kinetic chain. The pelvis rotates forward, pulling the lumbar spine into hyperlordosis and entirely altering the shock absorption mechanics of the lower limb. This tilted position structurally inhibits the gluteus maximus and medius, a phenomenon known as glute amnesia. With the primary proximal shock absorbers disabled, the force of impact bypasses the hips entirely and travels directly down the tibia. Because the pelvic tilt shifts the center of mass forward, the runner unconsciously compensates to avoid falling. They overstride, throwing their foot too far ahead of their hips to catch their own momentum. This overstriding guarantees a harsh, heavy heel strike. That impact exponentially amplifies the eccentric demand required by the anterior shin to stop the foot slap, rapidly accelerating the onset of anterior shin splints. This top-down view maps the ascending kinetic chain, revealing the mechanical link between the mid-stance phase of running and restricted internal hip rotation. During mid-stance, the body's entire weight passes over a single supporting foot. To advance forward, the pelvis must rotate smoothly over the femur, a movement that absolutely requires clean internal rotation within the hip joint. If the hip lacks this rotational mobility and locks up, the nervous system finds a workaround. The body borrows the necessary range of motion by forcing the tibia into a compensatory external twist relative to the foot. This structural twisting from the top down forces a reaction from the bottom up. The subtalar joint of the ankle is driven into a prolonged, exaggerated state of overpronation just to keep the foot flat on the pavement. This forced ground-up overpronation places devastating eccentric traction directly onto the tibialis posterior. The arch collapses aggressively, and the medial shin pays the price. The lower leg does not fail on its own. It is pushed into destructive compensatory mechanics solely to satisfy the biomechanical rotational debt created by a locked hip and a tilted pelvis. An effective rehabilitation protocol operates as a dual-action system. It must concurrently manage the acute local pain while aggressively reprogramming the proximal kinetic chain. Phase 1 focuses on acute protection. Practitioners use relative rest and targeted soft tissue release to calm periosteal inflammation. Simultaneously, posterior pelvic tilts, like the 90-90 hamstring bridge, are introduced to physically pull the pelvis out of its anterior tilt. Phase 2 restores proximal mobility and builds distal strength. 90-90 hip stretches restore true internal rotation in the joint. Seated soleus raises are utilized to build dense calf strength, as a strong soleus can absorb up to 8 times the body's weight, unburdening the tibial bone. Phase 3 demands dynamic integration. Exercises like step-downs require the foot, knee, and hip to coordinate under load. This trains the gluteus medius to actively control dynamic alignment, ensuring the tibia tracks properly without the foot collapsing. Phase 4 prepares the system for the eccentric forces of impact. Low-level plyometrics, like pogo hops, condition the tissue elastic recoil. Finally, gait retraining is implemented through cadence manipulation. Increasing a runner's cadence by 5 to 10% naturally curtails their step length. This single mechanical adjustment shifts the foot strike closer to the center of mass, immediately neutralizing the overstriding caused by the anterior pelvic tilt. With proximal mobility restored and the pelvic position corrected, The distal tissues are no longer forced to execute massive eccentric braking forces. The foot strikes cleanly, the hip rotates smoothly, and the shin muscles can finally perform their primary functions without tearing. True clinical resolution of tibial stress treats the body as a dynamic, interconnected system. By neutralizing the proximal culprits in the hip and pelvis, you silence the distal victim, breaking the cycle of injury permanently.